So next few minutes we'll be talking on the hypertensive retinopathy. So this results from the damage and the adaptive changes in the arterial and the arteriolar circulation in response to the high blood pressure. No visual symptoms. Some may report the decreased vision or the headaches. So this is the 4 grades of your hypertensive retinopathy. Grade 1 and 2 are the mild. Grade 3 is the moderate, and grade 4 is the malignant hypertensive retinopathy. So unfortunately, most of our people, they present in the moderate and the malignant. Very few people will be in the grade 1 to 2 of your hypertensive retinopathy. So what is grade 1 and 2? Here the generalized and the focal arteriolar narrowing, AV nicking, and arterial valve opacity, that is the silver wiring. So the weak association with the stroke, CHD, and the CV mortality. So the moderate grade, that is the grade 3, is the mild retinopathy and one or more of the following. That is the retinal hemorrhages, dot, blot or fame slip, and microaneurysms, cotton wool spots, heart exudates. So here, once you see the heart exudates or microaneurysms or retinal hemorrhages, so there is a strong association with the stroke, with heart failure, with the CKD and mortality. And in the malignant, that is a grade 4. Here the moderate retinopathy, that means exudates, your hemorrhages, your microaneurysms, and optic disc swelling and the macular edema, that is the papillary edema. So these are the very important. So once they have the optic disc swelling or macular edema, so definitely they are associated with mortality and they are associated with vision loss. They are associated with CVA, CKD, etc. So this retinopathy is very easy to diagnose the hypertensive retinopathy. So definitely, sometimes we have to at least once in a year or once in 3 to 5 years, one should be screened for the retina in all stage 3 hypertensive individuals. So this is a very big picture showing you the normal fundus. See the optic disc here. See the artery, retinal artery and the retinal vein. So the macula, fovea, and the optic disc. So on the right side, you have the abnormalities. See the normal retinal artery on the left side and see the retinal artery, how it is the retinal artery here. See the arterial narrowing is here. And then the AV nicking is also seen there. And whatever the exudates, so a lot of the exudates are there. It's almost like the moderate group, stage 3. And cotton wool spots are there. And the blot hemorrhages at 1 o'clock position. See the disc edema. And then the copper wiring, that is the arteriole. See the arterial narrowing, and then the nicking, and here exudates, and the cotton wool spots, and blot hemorrhages, and disc edema. So these are very much noted in this fundus. So this is the moderate. So what about the CKD? See, you know this staging of the CKD and calculate the GFR. So nowadays with the smartphones, it is very easy to calculate the GFR. Here you have to add the 3 points. One is age of the patient, and then gender of the patient, and then the creatinine levels. So creatinine level, either male or the female, sex of the patient, and then the age of the patient, you can get the GFR. And according to the GFR, you divide the CKD into the 5 groups. Stage 1 and 2, 3, 4, 5. And 3 is again divided into A and B. So stage 1, 90 plus. Stage 2, 60 to 90. Stage 3, 30 to 60. Stage 4, 15 to 30. And stage 5, less than the 15. R and dialysis. So 3 is again divided into A and B. Here 45 to 60 is the 3A. And then 30 to 45 is the stage B, 3B. See, but one fortunate thing, the most important thing in Indian people is, unfortunately, even all the CKDs, even at the stage 4 up to 4, they are asymptomatic. Most of the people, they don't have any symptoms till they reach the stage of the stage 4 or the 5. So that is the reason in all the hypertensive individuals and all the diabetic individuals, at least once in 6 months or once in a year, get the urea, creatinine and electrolytes. Very, very important investigation. So then you can identify these people to pick up at an early stage, and then with your dietary approach or with your ACE inhibitors or ARBs, definitely we can stop the progression of these CKD, or at least if even though if you are not going to stop it, at least you can slow down the progression of the CKD. That is, then you can give another 10 to 20 years quality of the life for them. Otherwise, within no time they can reach the stage 5, and then they will be on dialysis only till their death. See, it affects 8 to 10% of the general adult population. Those with early CKD are more likely to get a CVD event than the end-stage kidney disease. That all this point already I told you. So even though the creatinine level is between 2 or the 3 or the 4, even though they don't reach the stage of the stage 5, and most of these people they die, they get the cardiac events like acute myocardial infarction or etc. Stage 4 and 5, so definitely severe CKD should always be managed by the specialists for their dialysis workup. Here a case 55-year-old male comes to your clinic for routine checkup. Past medical history diabetes for the last 10 years and regular treatment, no history of hypertension. So he is a diabetic for the last 10 years. On examination BP 160/100. So 160/100 is undoubtedly an hypertension. So that is how very common association in our Indian people. So today's diabetics are tomorrow's diabetes plus hypertension. So hypertension will come at a later time after the diabetes. Same thing happens to the hypertension also. Today's hypertensive population are tomorrow's hypertension plus diabetes. So we have to see that these two are the deadly duo with the common environmental factors. So I have to keep the eye over all the diabetic individuals, whether they are hypertensive or not, because the presence of the hypertension in a diabetes, all the complications will be multiplied, and they will get the early complications. Whether your microvascular or macrovascular complications are more common in a diabetes with hypertension. See this fellow, blood pressure is 160/100, retinopathy grade 2, albumin creatinine ratio more than 30. So already he is a diabetic, now hypertensive, retinopathy, and also nephropathy. So investigation for the renal functions, including the calculation of the GFR. So drug of choice are ACE inhibitors or ARBs. They are the compelling indications to use in diabetic individuals. Usually 2 or 3 antihypertensive drug classes required to achieve the targets. Close monitoring of the renal functions is very important, especially the potassium. So drug treatment, hypertension and CKD. So single initial therapy is always a dual combination. So with ACE or ARB plus CCB is the one choice, or ACE or ARB plus a diuretic. So both are available right now in the market. Your Telmed H, okay, or your Telma AM. So that is your ARB plus calcium channel blockers, or your Silicon T. So the cilindipine plus telmisartan. So triple combination. So all the 3 drugs are available. Your CTD, TAM, etc. And resistant hypertension, we can use the spironolactone or an alpha blocker like beta rajosine, or a beta blocker like bisoprolol, etc. Here the beta blockers are the compelling indications to use in 4 situations. One is angina, myocardial infarction, post-myocardial infarction, post-PTCA, post-CABG. So that is coronary artery disease. And then in the heart failures. So compelling indications, 4 pillars in the management of heart failure. and one pillar is the beta blocker. And then the arrhythmias, tachyarrhythmias. So again, definitely we have to give the beta blockers. Why are ACE inhibitors are better? Because the improvement in the endothelial function. So they are not only then reduce the blood pressure, they are vasculoprotective, they are renoprotective, they are cardioprotective. So for a proper cardioprotection, renoprotection and vascular protection, so we have to use these ACE inhibitors or ARBs. The improvement in the endothelial function, reduction in the oxidative stress, decrease in the vascular inflammation and adhesion molecules, inhibition of the mitogenesis, regression of atherosclerotic plaques and LVH is superior to the Walder agents, inhibition of the proteinuria superior to the Walder agents, reduction in the new onset diabetes, and improvement in the fibrinolysis. So these are all the benefits of the BP control, benefits of your ACE inhibitors beyond reduction in the blood pressure. Here 55-year-old lady with a long-standing hypertension presents with nausea, facial puffiness and malaise. See long-standing hypertension. Now nausea, facial puffiness and malaise. So the pulse 72, blood pressure is high 160 by 110, edema of feet present, weight 58 kgs. So edema of feet present, nausea, facial puffiness. So she must be in CKD, chronic kidney disease. So suspect, get the creatinine levels, get the electrolytes, get the ultrasound abdomen to know the size of the kidneys. What do you suspect in this patient is a CKD. What investigation will you do? Urine examination shows proteinuria. Yes. Creatinine level is elevated, 2.5. Potassium level is the normal, 3.5 to 5 is the normal, here 4.2. If the potassium level is more than 5 or 5.5, so again hyperkalemia is also there. What stage of CKD does she have and how will you manage this patient? So now get the GFR, CFR. So according to the GFR you can identify. Suppose here this patient may be in the stage 3B or 4 or 5. So ideal drugs, ACE inhibitors, CCBs, calcium channel blockers, diuretics and combination therapy. Peripheral artery disease and its relationship with the blood pressure and need for the future research. What is an optimal blood pressure target? See high blood pressure. So if you keep the blood pressure at a higher level, so better perfusion, but increase your global CV risk. If you keep the blood pressure at a lower level, so impaired perfusion, but that definitely reduces the global CV risk. So symptoms in the peripheral arterial disease, you all know that claudication is very important. That is the pain on walking and relieved with the rest. And some people that develop the ulcers, maybe the vascular ulcer or ischemic ulcers because of the lack of the blood supply to the distal areas. Limb loss, so amputation is very, very common in Indian population with the peripheral arterial disease, and sensory disturbances will be provided if the patient is also a diabetic. So maybe a small fiber neuropathy. What is needed to solve this dilemma? Retrospective analysis of PAD specific and prospective well-powered trials. Compare the aggressive systolic blood pressure. Careful assessment of the preclinical and the clinical peripheral artery disease. And the standardized peripheral artery disease with the event at justification. Blood pressure targets. It needs to be stressed that the global problem resulting from the unrecognized and undertreated hypertension supersedes the potential harm from overly aggressive blood pressure targets, and until confirmed, these findings should not distract from the overwhelming evidence that treating and reducing the blood pressure in patients at risk for CAD improve the clinical outcomes. Patients with PAD should be treated to lower the systolic blood pressure targets less than 120 until confirmatory studies have been completed. So keep the systolic blood pressure less than the 120 in all the peripheral artery diseases individuals. So the management claudication exercises, rehabilitation program. Patient to walk until the symptoms develop, then rest and start again for a total of the 30 minutes. Walking increased by 5 minutes until the 50 minutes of the intermittent walking is achieved. Modification of the risk factors like smoking, diabetes, hypertension, hyperlipidemia. Weight loss is associated with a decrease in the risk of the cardiovascular disease, but has not been shown to improve the peripheral arterial disease. Foot care in patients with the peripheral artery disease is important for prevention of the ulcers. So these are all very important things. So current American Heart Association or cardiology guidelines recommend the antiplatelet therapy with the aspirin alone, 75 to 325 milligrams per day. Usually here in India we use 75 mg or 150 mg. Clopidogrel, it is available, clopidogrel is available in the strengths of 75 mg and 150 mg. Again we use either 75 mg or 150 mg to reduce the risk of the myocardial infarction, stroke and vascular death in patients with the symptomatic PAD. And we have the combination of the aspirin and the clopidogrel, 75 or 150. Other medications are celastazole. I told you that 50 to 100 mg. This is the peripheral vasodilator. And statins are the must in all the vascular diseases, whether it is a peripheral arterial disease or coronary artery disease or cerebrovascular disease, whether it is an hemorrhagic stroke or a thrombotic stroke, statins are the must. Not the low intensity statins, maybe at least the medium intensity or the high intensity statins. Here 60-year-old lady presents with the weakness in the left upper limb and lifting the weights, especially while walking. So weakness in the left upper limb. Pulse tachycardia 100 beats. BP 170 by 110. So hypertensive. Left arm 110 by 90. So there is a difference between the right arm blood pressure and the left arm blood pressure. So the right arm 170 systolic, here 110. Right arm diastolic 110. Here in the left arm it's 90. And her complaint is also the left limb only. So weakness in the left upper limb. The blood pressure is also reduced on the left upper limb. So the peripheral pulses are the felt. They are the normal in both the lower limbs. So no bruit heard on the auscultation. How will you evaluate this patient? So maybe the left subclavian artery occlusion. So evaluate for the PAD. So hemoglobin here normal, LDL is high, triglyceride is okay, HbA1c is also okay. So here the LDL cholesterol is 160, our target is 70. CT angio revealed coronary calcification, diffuse atherosclerosis of the arch and tight stenosis of the left subclavian artery. So left subclavian artery stenosis. So that is the diagnosis. Will you manage? Coronary angiography to rule out and medical treatment, aspirin, clopidogrel or lipids, high intensity lipids and BP control, sugar control, etc. May consider for percutaneous angioplasty. So thank you very much for your patient hearing.